Good evening again, everyone, and I know you're all probably absolutely sick of looking at my face these last 2 days. You'll be glad to know that this is the last session that I'll be partaking in tonight, because it's 11:20 here. As you can see probably by your screen, we have a wealth of experience here to answer questions for you. The lovely Dr. Brian McGeeney is going to moderate. So if you pop your questions into the chat, they'll then be directed, and we'll answer as much as we can. So without further ado, I'm going to hand you over to Dr. Brian McGeeney just to kick things off. And
Great.
Thank you for joining.
So thank you, Ainsley. And so folks who've attended the meeting have seen me once or twice, I think, and in previous meetings as well. I think it's my 11th or 12th. But anyway, and now is your chance to ask questions. And allow me to ask a burning question of the panelists. So Mark presented some intriguing data on a very well-conducted study on occipital nerve stimulation for cluster headache yesterday, and I have to admit, the results were a little surprising to me. Were pretty good or not bad. We can't always without a proper control. We can't properly discount just natural history or some other explanation. But my question to the panelists is, does this make it more likely that you're going to refer people for occipital nerve stim for cluster? I have to admit, I don't do that unless there's another, if they have a cluster plus syndrome, something else as well. But purely, I don't. Should I change my mind?
I haven't referred patients just because it is more invasive. I have sent people to pain specialists and neurosurgeons who do some deeper nerve blocks and will always consider occipital nerve block or other procedures as a last resort. So I'll be honest, I don't have much experience with it because I haven't really sent people for it.
Thoughts, Mark or Alex?
Yeah, go ahead, Mark.
I was going to say that I have not referred. I don't think I referred anyone for occipital stimulus, but I probably will, based on this data. If they kind of meet all those things, they don't respond to anything else, and I'm kind of, low on options based on this data. Now,
but an argument of, well, we don't have much else to offer is a weak argument for a procedure.
Agreed, but I think that looking at this data, if you failed several different medications, and the risk benefit is probably there, that it's higher. Now, I'm saying this as an interventional. I did interventional pain. We did put occipital stimulators in, so I have a different level of comfort with this, probably.
Yeah, probably my approach would be somewhat similar as well, especially if we're talking about intractable clusters that are very difficult to control otherwise, especially if they have responded, to an occipital nerve blocks in the past. During my years of fellowship at Cleveland Clinic, we also had patients with intractable chronic cluster headaches who were implanted with occipital nerve stimulation. At that time, we're talking about over 10 years ago. And some of those patients did really well with a relatively low side effect profile. And mind you that, the technology behind the neuromodulation has improved so drastically just in the past 10 years. So the risk of complications, even just surgical technique, they've changed. They've, been upgraded and improved so vastly. So I wouldn't use occipital nerve stimulation as my, first or second line treatment option, obviously. But for those patients who are struggling getting their clusters under control, I certainly see no reason why it shouldn't be tried.
Yeah, but it's quite an imposition and a cost, and it would be difficult to get insurance coverage. So it's an onerous thing, but relatively low, as procedures go, relatively low risk. We have a couple of questions already.
Dr. McGeeney, before we get to this question, do you mind if I turn around on you and ask you what your thoughts are on it?
Sure. A counter volley. I had a good look at the paper, and I couldn't see. I think it worked. Is it actually going to change my? I actually don't feel it's going to change my non-referral unless the patient really wants it. Whereas I might push back a lot if the patient wants it, and I won't now because there's some evidence backing it up. That might be the change. They'd have to be very keen on it. And I'm generally not in favor of interventional studies or interventional procedures for cluster into big ones. So to answer my own question, probably it won't affect my referral unless the patient brings it up themselves, I have to admit. But I hope that answers the question. Maybe it needs to be repeated. Now, overall, see the data, if you add up everything, about 2/3 of patients in the literature who've had occipital nerve stim reach the outcome of 50% reduction. And that also applies to deep brain stimulation, about 2/3 in the total. And that's not generally good enough for me, for an intervention, especially in the brain. Occipital, of course, stim, as you pointed out very clearly in your presentation, is outside of the skull. So generally, the summation of what's in the literature is not that appealing to me, I have to admit.
If I can mention just
Yep.
one point from a patient's perspective on this, because it's something that has been on my mind for whatever 20 years. I mean, when I first started this, they were first looking at deep brain stimulation at that point, and I think that there had been 6 people that had been tried on, and the report came back that only one of them had died, and that more investigation was warranted. So I was just starting down this trip, fantastic with the mushrooms, and I'm thinking, so they think that it's okay and needs more investigation and more millions of dollars poured into a treatment that only killed 1 out of 6 people, but the cluster headache community I can't suggest that they eat a mushroom. But and at that point there was a lot of money and a lot of research was going towards, that was when all this electrical stimulation stuff was really starting to hit it big. And I mean, it scared the death out of me that was where cluster headache treatments were going, was with deep brain stimulation. And but I'll always remember that since only 1 out of 6 had died, that it warranted further investigation. And so that alone was quite a motivating factor in my work that I came into.
So Jessica asks a rather it's a complicated question, and it involves around the anti-inflammatory effects of psychedelic agents, and do we think that could have something to do with their benefit? That's a complicated question. I mean, as has been outlined, and as we're familiar with, these are serotonin agonists, likely responsible for a lot, but not all of their effects. I can't say I know anything about, except, in fact, Dr. Schindler mentioned specifically the anti-inflammatory effects, I think, in your presentation this morning. Would you like to take that question? What do we know about the anti-inflammatory effects?
Yeah, so I didn't talk that much. I don't know if I mentioned it in this talk, but yes, there are absolutely anti-inflammatory effects of psychedelics, but that's an acute effect. That does not explain why you can go into remission after a single dose. So I have no doubt that there's anti-inflammation going on, but the studies so far have only really shown it in the acute setting. So
yeah, I would say yeah.
There is more research. There is more research going on now into the anti-inflammatory effects of psychedelics in other things, arthritis and other disorders. At least that's just getting started.
And so, before we move topic, anybody else want to make a comment on anti-inflammatory effects? All right. We're also asked about vagal nerve stimulation. or other forms of non-invasive neurostim, like are they safe for a titanium plate from craniotomy? Well, you know what? Dr. Alex spoke about the vagal very highly, about the vagal nerve stem, which I will take him up on. But before I do that, would you like to answer that question?
Yeah. So technically, any metal plates or electronic devices that are located close to the area of stimulation. So we're talking about the stimulation, the anterior lateral portion of the neck, where this pulsation of the carotid artery is. If there's a metal plate somewhere in the cervical spine or in the vicinity of, very close to that, then I would not recommend to use the non-invasive vagus nerve stimulation in this area. But if it's a remote plate, maybe in the parietal or other more distant location, then I believe it should be safe.
Yeah, so the answer is it is safe because you're stimulating in the neck region. So that's perfectly fine.
Yeah.
But while I have you on the line, do you think that the vagal nerve stim results in similar outcomes as an abortive compared to our other known agents? And the reason why I ask is their own data, because it failed to show a benefit as an abortive for attacks in chronic. Only in episodic. And I don't know of any other abortive agent for cluster which has this differential. And because of that, maybe it's not as good. What say you?
I've actually tried. So I was fortunate enough to be part of that clinical study when gammaCore was studied in patients with episodic and chronic clusters. In my personal experience, I've actually seen good results in both episodic and chronic clusters when it was used acutely. But based on the large trials, and there's several of them, there's ACT1, ACT2 trials. If you look if you kind of micro dissect them and look just into the chronic cluster subpopulation, then definitely the results, the trend was positive, but the results were not much different from the placebo. But if you look at the cumulatively or even separately in both of those clinical studies that were placebo-controlled randomized trials, the results were still actually pretty good. And that's what I see in my practice. So acutely, I use this device for patients with still episodic and chronic cluster headaches acutely as well. And I do see clinical benefit. With that being said, I rarely use gammaCore, or probably never use really gammaCore as the only treatment solution for cluster patients. It's always an add-on to something else. And I think that's probably a really important piece to it, because as we know, cluster attacks, they tend to occur in succession. There's multiple attacks in a day. Sometimes it could be daily for an extended period of time. So unless oxygen is readily available and is working, it's really hard to find another effective, reliable, and safe medication to abort so many clusters. With gammaCore, if it works for some of the patients, that's going to be just a great solution with almost negligible side effects, really. So that's my take on it. I use it. I see a clear benefit. And again, it's we're not talking about using just that or another. It's the combination approach, basically, when you're using pharmacotherapy with something non-pharmacological.
I also have good results with my cluster patients. I do, now that you mention it, I do feel that patients get, it's not 100% on the acute function, but I've had several subjects who have a really dramatic preventive effect with it. So that their overall burden is very much reduced, and they tend to use it for both the acute and the preventive functions. But I've noticed more of a preventive success. I've also had success with a trigeminal neuralgia patient and a patient with a mixed TAC syndrome. But this is also in addition to other medications. So the patient who has trigeminal neuralgia, it's secondary to multiple sclerosis, and he's also on Tegretol. And so that medication was losing efficacy, and the VNS just got rid of all of his.
So the questioner said that their neurologist was negative on it, But it seems there is no downside to treating episodic, and they're correct. There is no real downside. There's no danger. There's no health concern. So even though it's electricity, it's a very small amount, and there is nothing to worry about from that point of view.
This is also this treatment's also covered by the VA. So if any veterans out there are having a hard time getting it, send me an email and I can put you in touch with people who can get it for you.
And also there are some programs available now for patients to get started on nVNS for cluster treatment or migraine treatment for that matter. Yeah.
That's good. That's great to know. While we're asked about sphenopalatine blocks, and maybe the question would be, what role should this have in cluster headache? And no one will discount that you may block temporarily nerves, but does this have a role, and does it have a role just as an acute treatment, or is there any role for chronic treatment? What do you guys think? Sphenopalatine block.
I haven't seen a lot of data on it as far as people doing studies that shows that it's effective, it's not effective, anything. I think there's a few different ways to do it. You can kind of go back up the nose with either a long Q-tip. We talked about this in one of the the Friday night chat one that's still going, but just like the COVID kind of thing, and you drip some lidocaine, or you can do it through a needle through the side of the face. The one through the nose obviously seems to have very few, if any, downsides to it. As far as you might swallow a little lidocaine, doesn't taste great, but there's not a lot of downsides. But I don't have a lot of experience with it myself.
I've actually used sphenopalatine ganglion blocks for quite some time now, for not only for cluster headaches, but also for atypical facial pain and idiopathic facial pain. Was really, not 100% success, but very good success rate. And in fact, early on, before all this intranasal devices, I should say, maybe became available, I used to do a lot of interventional sphenopalatine ganglion block with the needle using infrazygomatic approach. It was the fluoroscopy, and we had good results. I wouldn't say that at that time it was used for anything more than just as an acute intervention for an intractable cluster cycle. It's never was like repeated on any consistent basis. But now that we have a number of very easy to use intranasal, devices, whether we're talking about, TX360 or the SphenoCath, there's quite a few. You can use the Q-tip. I know that some providers use the AngioCath and then just drip the medication through it. It's a very simplistic procedure. I do think it works. It depends on how accurately the procedure is performed. So if we use, let's say, regular lidocaine nasal sprays, well, the sphenopalatine ganglion is located in a very specific area that's very hard to get with the regular sprays. So ideally, you want to either put that Q-tip right next to the location and then soak it with the, like they used to do 30, 50, or 60 years ago, they used to put 2 or 3 Q-tips up each nostril, almost like packing the area with the lidocaine. In the beginning, it was cocaine that was actually used, and patients loved it. Well, it's a joke, but it worked. It worked really well for patients.
When you say it works, what's your outcome? Are you trying to import an individual attack or do more than that?
It's almost like more than that. So whenever I do it for cluster patients, those are the patients who would come in and they're experiencing attacks daily. And we do this nerve block, let's say. It may need to be repeated maybe a week later, but patients notice a reduction in their headache frequency for that short period of time. Now, I don't think I had enough patients who were in chronic cluster when we tried it, let's say, on a weekly or multiple times a week, for instance, to see if that has any impact. But for episodic cluster, it certainly works like a cycle breaker, if you will, to shorten the duration of the cluster attacks or the cluster cycle and decrease frequency. We also did a study for kind of as an extension of that sphenopalatine ganglion. We also did a study of the sphenopalatine ganglion stimulation. Was one of the companies that was a few years ago. It didn't really materialize into anything major, unfortunately, although the results were very, very promising. There was a technology. It was a very small device that was actually implanted through the oral approach with a little incision at the gum line. and the device was secured to the maxilla with just 2 tiny screws. And the little stimulator lead was going into that infrazygomatic space, into the sphenopalatine ganglion fossa, stimulating the SPG and the VDN nerve specifically with a remote or external, rather, pulse generator, I guess. Nothing is implanted beyond that little device. And we've seen good results. It was pretty easy to do procedure. Results were good. It's just, I think we didn't have enough patients to really say that that was the consistent, outcome. Unfortunately, the study was, completed, but the company that was in charge of this, unfortunately, went bankrupt. And,
so Alex, we have a very prominent member or well-known member of our group who got that procedure done and developed a neuralgia immediately on insertion, likely trapping one of the alveolar nerves. And I think he had a year of hell from that alone. But he still has the stimulator and he still works it, even though, and I think he has to hack it to get it, and has handheld devices sent to him. So isn't that right, Paul?
Yeah, and I mean, it's possible that help is on the way, because the scientific property was purchased by another company, and they got FDA approval on it before they were even ready to do anything with this company that they bought. So the last I had heard, they're still trying to put this company together and bring that product back to the market. So all
that
those
would be
people
great.
that
would be great.
Yeah, because a lot of people were left in the lurch. You have something installed in your body, and all of a sudden, the company that put it there isn't around anymore, and they couldn't even get an email answered. So, and some people were having really great success, and they were like, well, how am I going to keep on using this? What happens when my handheld device, dies and everything else? So hopefully they will be able to pull all that together and at least take care of all the people that have already,
I was more excited about that than I was about the superficial stuff. I'm more excited. So rolling on with the questions, I think Jason asks in jest, I hope, has anyone ever attempted hemispherectomy to treat cluster? Well, they stopped even cutting the trigeminal nerves years ago, let alone removing a half of your brain. So I think the only folks you will find who've had half of their brain removed was possibly a failed attempt at self-expiration. And that's not, don't even think of that. I'll tell you what would happen is you develop cluster on the other side. Then what would you do?
Yeah.
So destructive procedures, I'm not a great fan of in general.
On that note, Dr. McGee, I have thought for the occipital nerve stimulators or the sphenopalatine ganglion, should you put them in on both sides right away, assuming that it might switch sides if you can control it on one side? It's probably too much, right? It's an extra surgery. Now, one with the occipital, you might be able to do one surgery that crosses both. But
yeah. But the sphenopalatine stim, probably again you are putting yourself at risk of the complications.
Right.
So we're asked about what research do we know about the circadian aspects of cluster headache, and would things like monitoring our REM cycle or sleep pattern help? Allow me to make just a comment in that there are a couple of studies looking at sleep cycle and cluster, and to best of my interpretation, one can't be. It's a bit all over the place. That you can't consistently say it's going to happen in such and such a cycle. People do vary as much as to be not that helpful. But as regards the circadian aspects, that's a more complicated question. What are panelists research into the circadian aspects?
I wanted to mention that as part of the psilocybin cluster headache study, I'm starting to have subjects wear an actigraphy device, before and after treatment to see if what the baseline circadian rhythm is, and this device also measures sleep onset and also different aspects of the sleep quality. So that's going to be a follow-up results that I'll have once the study is done. But I'm looking at it because there definitely is something about the circadian cycle and sleep. And I'm interested to know whether psychedelics have an effect on that. There are early studies in rats that do show that LSD and also BOL have effects on the sleep cycle in rats. And there are a couple of human studies that also show changes, lasting changes, more than just one night, but several nights, or even over a week of sleep improvement after a single dose of psychedelics. But these are old, uncontrolled studies, so I'm hoping to look at that more carefully.
Yeah, I think the circadian part is a big part of our research, and so just a brief thing with the circadian, it's kind of a fascinating thing for cluster headache. It's one of the few headaches other than hypnic headache that happen for a lot of people at the exact same time, almost like clockwork. There's not a lot of pain conditions where that happens. So there's something unusual about it. And if you look, it's not everybody, obviously, but a lot of people. There are a lot of other circadian changes. The two circadian hormones are steroids and melatonin. Those are altered in cluster headache patients. Those are also treatments for a lot of cluster headache patients. And it turns out a lot of the medications that we use, not just steroids and melatonin, but lithium is a well-known circadian modulator. We just published a study of verapamil as a circadian modulator. So maybe there's something with the medications too. So I hope to answer that question over my career, if the circadian cycle is important or not, but I don't have an answer for you yet.
Mm-hmm. Thank you.
Right.
And Tony tells us that in a Finnish patient community of 2,200 members, that's, I take it, of cluster, there are lots of patients with the occipital nerve stimulator. Around half of them are getting a reduction, but no one is getting remission. Those who don't get decent response proceed to some form of self-treatment. And all right. So certainly not great responses. One moment. Hopefully you don't get too much. I'm having too much sound coming through here that shouldn't come through. We have somebody with the vagal nerve stim who also has titanium plate and screws at C4 to C7, but that'd be more posterior, and you're approaching this more anterior. So I think that would be okay. Dr. Alex, what do you think?
I would, so in that case, I definitely would be more careful, because the C4, it will be coming somewhat nonetheless close. So I'd probably say if there are any titanium plates in the neck, I would be very careful. Probably wouldn't be using it, frankly. If it's in the cranium, a thoracic region, it's probably okay. C4, this is kind of the borderline. I would consider that as being relatively close.
Okay. And we're asked, Justin asks and states that he has not got relief from oxygen. And it sounds like he's used the CH mask, high flow, at the start of an episode. Is there a reason why oxygen doesn't help? Maybe can I ask the patient or folks, Bob and Mark and Ainsley, what's your experience with people who say they don't respond to oxygen? Any comments on that?
Yeah, I mean, I get a lot of questions sent to me, a lot of messages saying that, they're using oxygen as directed and not getting any relief from it. I don't know what Mark and Bob think, but personally for me, I think, obviously there are maybe going to be some people that it doesn't work for, but I personally think that's a low percentage. And I think the people that it doesn't work for are perhaps not using it correctly. And Bill Mingus did a great oxygen demonstration with some top tips and tricks to try and help the effectiveness of oxygen and to try and lower the abort time. So there are little tips and tricks which I personally use. Now over here, our tanks have integral regulators up to 15 litres per minute, but I also have a demand valve. So for me, I think it's really important before you even take your first inhalation to totally expel all the air from your lungs. Really kind of huff it out. and then do the same as you breathe in. Really huff it in. And what I do is I kind of count. I'll maybe do 5 or 10 breaths like that in and out, and then I'll do mild hyperventilation. So, you know, as if I'm sort of blowing out a candle, you know, so, you know, obviously when you're restless within an attack, so it can make you feel a little bit dizzy. So do bear that in mind. But it works for me. So I really do think these top tips and little tricks that people have just really found by accident are things that perhaps people who say oxygen doesn't work for them should perhaps try. I'd be interested to hear what Mark and Bob think.
Well, go ahead, Mark, and then I'll jump in.
Okay. I'm not really sure what to think about that. I know that in my experience, oxygen has almost always helped me. There have been times when it didn't, and I don't know why that happened. But there were attacks that I could not abort with oxygen, and I know when I was in the hospital, I was unable to abort with oxygen. It just was not happening, and I think it was related to the treatments. But that's just my layman's sort of assessment. But so I don't know, and I feel kind of helpless to help folks who say that oxygen isn't helping them. I wish there was something I could say or do that would, you know, make it work. But I don't really know what to offer when someone has that experience.
Yeah, I think speed is key, isn't it? You know, obviously nocturnal attacks, when you wake up to them, they're already very established, and those are the ones that I generally, you know, 9 times out of 10 cannot abort. But a daytime attack, you know, if I could get on it straight, and when I say straight away, and Bob, you talked about this earlier in our session before this, about how important it is to take those little niggles very seriously, because I think as patients, I'm sure Mark and Bob will agree that we, even when we've been doing this for decades, we still kid ourselves on and say, you know what, it might not come to anything, but it always comes to something, you know, and I don't know if that's a little part of denial or whatever, but yeah, definitely I think speed is key.
Yeah. I'll just add this on the oxygen. I agree with Mark and Ainsley on this. There have been times in the last 40 years where oxygen didn't work for me either.
Yeah.
But it was short-lived periods of time that it wasn't working. So, you know, I don't know exactly what it was, whether it was a medication that I was on that was making it more difficult. I know that for a lot of people, oxygen works better after they've done psilocybin.
For sure.
If never worked at all for somebody, and then after they've done a couple of doses, that's all they ever needed again to abort attacks. But in all the other cases too, I mean, the people I've talked to that have mentioned that it stopped working, eventually it started working again. Maybe it's just something that we change our breathing patterns. Maybe, you know, some people have success with one method and the next person it won't work at all for with that method. I mean, some people hyperventilate and they huff and puff and within 10 breaths they've stopped the attack. Other people would rather sit back and try to calm themselves and breathe slowly and breathe more normally and just take deep breaths. But if they try to huffing and puffing, they don't relax enough to be able to stop the attack, they think. So part of, you know, calming down is part of the process of them trying to stop the attack. So like Ainsley said, I think you just need to try all those different tips and tricks until you find one that is going to work for you, because I'm sure there are people out there that it doesn't work for, but you just got to keep on trying.
Yeah, I think sometimes also even mid-attack, you know, when you've maybe been on for 15 or 20 minutes and you're getting nowhere, you know, I come off and then, you know, and ride it out for 10 or 15 minutes more and then try again. And sometimes it works second time round. You know, so it is really trial and error, and we're all different in how we respond. But, you know, just doing that and noting the results and say, well, you know, didn't work for the first 20 minutes, stopped for 15, tried again, and it worked then. So maybe
Yeah.
I'll try that next time.
Yeah.
Yeah.
Yeah, I mean, and nothing works for everybody. And so with any treatment, even very strong treatment, there'll always be exceptions. And it sounds like Justin probably has gone through carefully everything.
Yeah.
And it just be
yeah.
one of these things.
Yeah. That's unlucky.
Yeah, you know, I don't like telling anybody that, you know, they're probably not doing it right, because
Yeah.
that it isn't the case. You know, some people things just aren't going to work for, and I'm sure that they've tried. I mean, if you've got something in your hand that you think is going to end that attack, I mean, you're going to keep trying it until you got to give up on it. But
Yeah.
yeah.
And I mean no offense when I said, I was generalizing when I said,
Right.
you know, people who pose questions to me
Yeah.
by email or by message saying it's not working, the first thing I ask is, well, what's your technique? Tell
Right.
me what you're doing. So please don't think I meant any offense. It was nothing personal.
Yeah,
And
no, I know.
I'm reading the message now, and I realize that, you know, this person is obviously doing everything right, and perhaps he's just unlucky, and I'm sorry for that. But I would say don't give up. Try again.
Yeah.
And Justin, if you ever manage to challenge yourself with very high flow, maybe 25 liters, let us know. Or if you find an answer to that, we'd be delighted to hear your experience.
Yeah.
We have, so Lonette says that she just had the SPG nasal injection last week. She's chronic. It didn't do anything for her cycle, unfortunately. And Jared, as SPGs, chronic, mostly takes the edge off. And they were asked about cranial osteopathic manipulation. And would that have any role? Well, when I sometimes think of craniosacral therapy, hands-on therapy, and I'm open-minded with respect to migraine, but cluster, I'm not so sure. What do the panelists think?
Yeah, I totally agree. I use it sometimes for patients with migraine with significant occipital pain presence, like with this occipital phenotype, so to speak, not per se classical cervicogenic headaches, but migraineurs with occipital pain. I do feel like it might be beneficial with clusters. I haven't seen much based on my experience to say that has changed somebody's life dramatically. I think it's worth trying as far as additional thing to alleviate some other symptoms. For example, some patients can get the severe muscle spasticity on the painful side. We see it frequently. And I just wanted to quickly comment regarding that SPG blocks not helping right away, just taking the edge off. So the study that were published, some of them were placebo-controlled. Actually, one of them was published here in Chicago, was done when they used these phenopelvic ganglion blocks. It wasn't for cluster per se, it was for atypical facial pain or idiopathic facial pain. And the procedure was performed every other day, I believe, or 2 or 3 times per week for a 3 to 4 week course. So, and that has been my experience as well. Maybe not, I'm not doing it for every patient this frequently, but I would encourage to repeat at least 2, 3, 4 of those, intranasal nerve blocks to give it a chance to work. Very frequently, single blockade may not necessarily yield great results. It's repetition sometimes that actually can give better results. So I would encourage, if there are no major side effects, which there shouldn't be really with intranasal administration, to just repeat it a few times, maybe like on a weekly basis for 2 or 3 weeks.
And thank you for that. Tony comments that his own opinion is that it looks like those who are taking a lot of pharmaceutical agents, he thinks that might be associated with non-response to oxygen. And then the approach would be to detox from medications, and feels that's his opinion based on interacting, I'm sure, with loads and loads of folks.
Yeah,
so Tony's been very active.
Yeah, he is and is in touch with a lot of patients, and yeah, I mean, it's an interesting thing. I read his comment there, and so my point about that oxygen seems to work better for people that have tried psilocybin. And his point is, well, maybe it's not the psilocybin, but that the psilocybin allowed them to stop using some of the other medications that they were on that actually made oxygen more effective for them. And so it's more the cause than the effect, or the other way around. So, yeah, it's a good point to think of, Tony. Thanks.
Yeah, I find that very interesting.
Yeah.
That is. And we're asked about trazodone and psilocybin. So the use of trazodone and psilocybin, it really comes. It's another one of those. Can you use X when you use psilocybin? And the first thing is to say, I think Dr. Schindler would say as well, we just don't have studies on that. And further, trazodone has multiple actions. And so multiple opportunities for maybe concern. Anyone want to take that further?
Well, I wanted to mention that for the studies, we didn't allow patients to be on a sustained serotonergic like trazodone or like an SSRI, because there was concern that maybe the long-term changes to the serotonin system that happen when you're on those drugs might not make the psilocybin work. And I've sort of heard that buzz from cluster busters. If you only take trazodone once in a while to help you sleep, it's probably along the same lines as taking it with a triptan. They're serotonergic, but if you haven't altered your entire serotonin system, which is what happens when you take a serotonergic chronically, then it's probably okay.
Yeah, see, SSRIs result in a demonstrable downregulation of serotonin receptors in the brain. It's quite marked. And we think that's the reason why, if you're on an SSRI, you won't necessarily get the same psychedelic experience, if at all. So it's a blocker. And it's a blocker mainly for that reason. That's my understanding. But that's SSRIs. Trazodone is not an SSRI. So we're asked, so the answer, and with the preponderance of safety, one should come off as much medication as possible. And really, and that's a very, very good rule to go by. And I'm glad that Cluster Busters had that rule for a long time.
Yeah.
And we're also asked about the role of carbon dioxide. Now, that can have multiple aspects to that. There's even a treatment that was looked at where carbon dioxide, was injected up the nose in a session of migraine. Although I think the studies have discontinued on that. But maybe the questioner one is wondering about the role of carbon dioxide in possibly triggering an attack. I'm guessing here.
Yeah, I don't know.
But I don't think it's more common. The more reliable way to trigger an attack is to go to altitude, or is to reduce the partial pressure of O2, and you'll only see that if you're climbing very high mountains. Is that been you've heard of that, Bob, right?
Yes. Yeah.
And Ainsley has had, I think, an experience in that respect. Climbing to elevation.
Yeah, it was really weird actually in Denver at the conference. Myself and Graham and Steve and Heather Kessinger, they drove us for miles so that we could climb Pikes Peak, which I think was, if I remember correctly, like 14,500 feet, something like that. And you get to the top and you really want your oxygen for different reasons. But yeah, I had quite a vicious attack that, just kind of came out of nowhere, out of cycle, just, obviously to do with the elevation. And it kind of happened, and I took myself off to the ladies' room, and it was the weirdest attack I ever had, and the shortest. 10 minutes. It disappeared as quickly as it came. It came on very quickly. It wrapped up very quickly. It didn't last long, and then it just went like that. And that's the first time that's ever happened to me. Anyone who knows me knows I travel a lot. I fly a lot, and I've had attacks mid-air in cycle, but I've never had anything when I've been flying out of cycle. But climbing Pikes Peak, as spectacular as it was, did induce a cluster, and actually it induced some activity, some unpleasant activity, but not a full-blown attack for both Steve and Graham.
And that's very. And how? What was the elevation again?
If I remember correctly, it's about 14,500 feet, or
Wow.
14.7 thousand feet. It's pretty high. You know, you drive most of the way up there, and your ears are popping, and all the rest of it. And then the last 5 miles, they take you up in a minibus sort of thing, you know, and you get out at the top, and spectacular. It was wonderful, but we. The 3 of us were cluster heads, and we all had activity. But as we started to come down, as Bob talked about earlier, when you bust, it's like losing that that pressure. You know, you feel that pressure as you're going up, and as you're coming down, the pressure starts to come down along with it. But it was just you know, an isolated incident for me. I've climbed a few Munros in Scotland, a few mountains, and not had anything like that. So for me, I don't know, maybe it'd been the time difference, and who knows? We can't explain it, but definitely something happened.
That's a very interesting observation. If only, and in particular, because there aren't any other way. There aren't ways in the literature where you can trigger an attack when you're not in cycle.
Right.
That's the only way, in my understanding, where you can trigger an attack when you're not in cycle.
Yeah.
And is to drop the oxygen amount, and that doesn't occur so much in the plane because the plane is pressurized to a higher amount.
Of course. Yeah.
I just want to jump in here and say that I'm really glad that we changed the screen here, because Emmanuel's been sitting to the side of Brian there, and I've been worried that Emmanuel's cat was going to jump from one screen to the other and eat a bird right in front of all of us here. So I'm glad we rearranged.
I just hope you're not hearing too much in the way of tweeting.
We hear the little tweets, but it's
Yeah.
really, it's
Yeah,
really
I wouldn't
cute.
worry about me hearing the tweeting. I'd worry about Emmanuel's cat. So
Yeah, they just left the room. They're on their way to Boston right now.
okay. Yeah.
Some people commented that they thought there was like a squeaky wheel going somewhere. Like, does somebody have a rodent or something running around? But I guess it's a bird.
I'm trying to
It's a
mute
bird.
myself occasionally so it doesn't.
Yeah.
How are we for time?
We are well over time.
Sorry.
No, that is totally okay. It is absolutely cool. I did want to say that we brought Mary Franklin up to the stage to join everybody because, as we did at the beginning of this conference, we wanted to welcome her to the board of Cluster Busters, but she seems to be having some issues with her camera, and I don't know if she can hear us at all even.
Hi, Mary.
Mary, are you there?
Shall we continue with the questions, or I'm at your service, Eileen?
Well, I think that so Caitlin and I have some stuff to do to prepare for the evening session, because the evening session is going to require a lot of videos and stuff. But we do still have the open chat. And so I think at this time, I'd like to welcome people to jump over to the open chat. And anybody who's here, if you have time and want to join us in the open chat, that would be amazing. I really want to thank everyone for being here, joining us. Dr. Feokhtistov, Dr. Schindler, Dr. Burrish, Dr. McGeaney, and the Cluster Busters board. I also want to take a moment to do kind of the closeout thank yous for the conference, since tonight when we're done the Grow demo, it's going to be, there's Mary.
Hi, Mary.
Hi, Mary.
Hi, Mary.
Yay.
Okay. I was using an external camera and it's not working, obviously.
no.
I just want to thank the board for inviting me to join. I've known about Cluster Busters for a long time. My first real work with Cluster Busters was my first Headache on the Hill. There were only 3 people from Illinois that went. It was Mark and Bob, and these guys were total stars. I just sat back and listened, and they were very engaging, and their stories were brilliant. So thank you again, and I'm anxious to help you guys with your work.
Well, we're really pleased to have you with us. So it's going to be great. So
Okay.
welcome aboard.
Thank
I'm
you.
really grateful to have you.
Thank
Yep.
you.
Great. So are we?
Awesome.
So, what do
So,
you?
so yeah, Mary, I'm so glad you're here. I'm so glad you could jump in. And I did want to say just some brief thanks because, like I said, at the Grow demo this evening, we'd still like you to come for it, but it's going to be very late when we're done. And so I just want to take some time right now to first thank the board of Clusterbusters for your support. I want to thank Caitlin, who has been here helping run the conference. Caitlin, I know you don't like being on screen, but for this one brief second, I'm going to make you. Yay, Caitlin. Michelle, who is at home, also has been behind the scenes the whole time helping us, although she rocked it out at Trivia last night. I want to thank all of the volunteers that have been monitoring all of our chats and our open session. I want to definitely thank all of our speakers who have lent their amazing expertise to this event. I want to thank Bob Wald for making Cluster Busters, because without him, none of this is. And I want to thank our sponsors for making this event possible: Eli Lilly and Company, Ceruvia, Electrocore, Praxis, and Two Fun Guys. Thank you for supporting Cluster Busters and making all of this work that we've been doing possible. So that's all I have. Anybody else have anything?
I would just like to thank you, Eileen, on behalf of all of us, because you have been amazing, and you are sometimes behind the scenes, and I know you don't take compliments very well, nor does Bob, but we all have commented and we all recognize the very long days and long hours that you've put in to put this conference together in a short space of time. So on behalf of your fellow board members, we thank you. Total respect.
Yep.
What a wonderful job. Thank you
Yep.
so much.
Wonderful
You're
job.
very welcome.
Good job.
Absolutely. So
And-
can I
and-
go to bed now? Is that okay?
Yes, you can go to bed now.
Yes.
And just one shout out to Ainsley, who says that she doesn't understand technology. I think she's lying.
Yeah, I
Oh,
think so
it
too.
was
She's
a
done a
way
great
up
job.
there. I struck lucky. Yeah,
Nice.
as I say, I'm going to call Apple and see if they're looking for any Apple geniuses. You know,
Yeah.
I've come up in the tech world now. Thank you all for your patience and for helping me along, and great conference. And I'm going to sign off and go to bed now.
Okay. We'll see you tomorrow. Have a good night.
All right,
Good night.
guys, have a good night.
Yep.
Bye.
Thanks, guys.
Bye.
Thank you, Eileen.
Bye.
Thank you.
Yep. So we're going to close this one out, and we can all go to